Hey Doc, this is Nick. We are looking at this case together with the question of whether or not to restore these implants, which were placed by an oral surgeon. Fortunately, you had the ability to take a CAT scan so that you could see things in 3 dimension that maybe the average restorative dentist might not see when an oral surgeon says, quote unquote, go ahead and restore and everything looks good. So I'm going to I want to start this conversation as if I placed the implants. So this is what would be going through my head if I had placed these implants. Let's start with the implant number, looks like number 14. In general, in the upper arch, we have a couple different ways of doing sinus lifts. But some of those techniques didn't exist a long time ago. And what surgeons used to do is they would actually place the implant intentionally through the cortical bone, the inferior border of the maxillary sinus, but intentionally not perforating the Schneiderian membrane. So I think the concern here is that this is quote unquote in the sinus, but to our surgeon, they would probably say something to the effect of, we have no idea if that's in the sinus. And if it was, I feel like you'd see a lot more vertical bone loss around the implant. If this implant was communicating with the anaerobes found in the sinus, this thing would be toast yesterday. So I think it's easy to cast judgment that this is placed in error, but this was an intentional approach once upon a time. And knowing that this oral surgeon was trained decades ago, it's very possible that he did this intentionally. My hope is that he actually did an internal lift and the graft just didn't take because there wasn't enough heme to stabilize the internal bump that was attempted. With that said, we don't have the notes at this point in time to gain some understanding whether or not that happened. But this outcome alone, looking at the periapex of the implant, is not a reason in and of itself to recommend that this tooth this implant get taken out. Now we also have what looks to be some active sinus inflammation or mucus buildup within the sinus. Yes, it's coinciding with the implant. So if we take this and we pan around, it does look like that particular issue is isolated to the implant, but it's very possible that the bone in this area knows that there's something going on, and there's just a lot of active inflammation and sinus buildup because the normal drainage pattern is being disrupted by this bump of the implant. So this in and of itself, not concerning. I think what I would do is I would just monitor this. I don't think I would necessarily take the implant out based on that alone. With that said, if I took a CAT scan in a couple months and I started to see degradation in this direction, then I would definitely think there's something going on. In general, when the sinus is involved with an implant and there's infection, it pretty much rejects the implant almost immediately. Anaerobes are very aggressive. The body's response to anaerobes are very aggressive. This doesn't scream to me that the body's rejecting the implant based on this alone. Now, clinically, are there threads showing here? Looks like the buccolet's good. On the lingual, maybe there is potentially some lack of bone encasement of the implant. With that said, lots of implants, especially in the upper arch, have this on the lingual. Thanks to very thick keratinized tissue, these tend to do very well because of the fact that the tissue doesn't move. These tend to be very stable. There are many implants out there with this. It's just with CAT scans, we can often see things with a magnifying glass that we couldn't see before. So definitely not ideal, but I don't know if the surgeon would look at this and say this needs to be redone. So when it comes to this implant alone, I would do an Ostel. If the Ostel comes back to solid reading, then you know this bone is good. Yes, it's possible that this isn't ideal, but I just don't think that's necessarily going to cause the case to be a failure. Maybe we do a smile composer from Glidewell, just a plastic, temporary, give it a year, rescan, see how it does. Because sending this back to the surgeon saying, you did something wrong here is likely to end up in a much more difficult situation than just slapping on some temporaries and seeing how it does. At the end of the day, if the surgeon says they look good, and we restore, we're not at fault here. As restorative dentists, we are not surgical experts. Yes, we should kind of sound the alarms when things don't look good, and that's what you're doing here. But I don't think I would necessarily try to make something out of nothing. That's where my head's at with this particular thing. Is it's possible that we're not surgeons, we don't see this every day, but to a surgeon, this is perfectly acceptable. So that's that implant there. My recommendation for that is to restore it with a temporary and see how the patient does over time. Coming down to the bottom, at first glance, it looks like these implants are placed rather aberrantly or off axis. I don't know if a surgical guide was used in this particular case, but I can tell you that surgeons are always looking for maximizing the amount of bone that they have. If we look at this dip here, we can see that in between the implants is actually the bottom of the crest of bone, meaning that the distance from here to the nerve is probably the least quantity when compared to here and here. So it's entirely possible that the surgeon actually placed these implants where they are because that maximized where the bone was. Could he or she have placed shorter implants? Let's see how tall these are. It's a 10 millimeter implant. One could easily say that maybe a 7 should have been placed and placed in a normal location. With that said, I don't think it's clinically unacceptable. The angle is not great, but look how close to the nerve the surgeon was. There's just not a whole lot of bone here. So it's entirely possible that the surgeon said to the patient, look, we can do some ridge grafting, but ridge grafting comes with its downsides and potentially poor outcomes, and it's very expensive to do. Why don't I just place some implants to the best of my ability, and we'll just deal with the complications as they arise? Is that substandard care? No, there's nothing wrong with that if the patient was educated about it. We don't know because we don't have the notes at this point in time whether that conversation happened, but just trying to play devil's advocate here, it's entirely possible that was true. So although not ideal, the angulation of these implants is not great. It's going to be kind of challenging depending upon how much the patient can open to get implant drivers into this guy, but we have the right angle drivers, prosthetic drivers in the practice, which should really make that entirely possible. Not being parallel, that's fine. We'll splint them together anyways. When we splint them, the parallelism of the implants really becomes a non-issue because of the fact that we're going to use non-hexed or non-indexed impression copings, or at least one of them will be. So not great, but maybe it was intentional. But I don't think this is substandard care. Now, coming to the fact that you had pointed out that there's a lingual cortical plate perforation, these happen all the time. There was a paper done years ago, and it wasn't a scientific paper. It was more of like a letter to the editor in a good journal. And it was an oral surgeon who made the point that he had placed tens of thousands of implants. That's how I remember the story. Maybe it was just thousands, but it was a lot of implants over the course of 30 years. And towards the tail end of his career, he got a CAT scan, and he was blown away at how many of his implants actually had this lingual cortical plate perforation, and they were perfectly stable. He even concluded that this is actually, by design, creating what's called bicortical stabilization of the implant. I'm not saying we should do that, but that was his takeaway, was that if you actually grab this cortical plate, then you're increasing primary stability and long-term stability of the implant. If it perforates enough that it gets the lingual artery, the lingual nerve, obviously a different story, but that's not necessarily likely here. This looks like it's a pretty minimal exposure. If this was to cause a problem, it probably would have caused it by now. I'd be super concerned about how close that was. With that said, the patient's not discussing any paresthesia, and it's really up to the surgeon to handle that. So I would assume that that's fine, just a lot closer than I would have liked to have placed. Lastly, you had mentioned that there were some threads showing on the lower implants. It doesn't look like there's any lingual thread showing on this number 18 implant, call it 17 and a half, maybe more in the buccal. If there are threads showing clinically, then yeah, maybe we send this patient back and we outline some of the things with the focus on the thread showing. Thread showing is concerning enough to warrant sending the patient back. We could just write the letter saying, Mr. Oral Surgeon, the patient was stable when you last saw him, but it's been a significant amount of time since the patient could save up for the prosthetics. Now here we are, we have threads showing. That concerned us, so we took a CAT scan, and here are some other findings we'd like you to take a second look at. That's a pretty non-abrasive way of taking care of the patient without trying to tell the oral surgeon, especially the more tenured oral surgeons, that some young restorative dentist knows more than he does. So that's how I would approach that, is let the thread showing be the focus of the attention, and then just bring in some of these other points saying, we would like you to take a look at it again. Advocating that this patient see another provider in the practice, I'm not sure I would take that approach. Very possible here that there's some thread showing. But keep in mind, thread showing on a CAT scan, or what we think would be thread showing on the CAT scan, does not mean the threads are showing through the mucosa or the attached tissue. There are implant designs that actually allow for that kind of placement, BioHorizons being one of them with their laser lock technology. That's not what this implant was. I believe this looks more like Nobel, but I would be very careful in saying this is an acceptable outcome based on the fact that it's not completely encased in bone on the CAT scan. With that said, you did say they were clinically visible. That is a concern, not something I would want to slap on some fresh crowns on. There are ways of managing those situations, but typically we're managing those situations in old implants that have been there for a decade or two. We're just trying to keep what's there healthy, not starting a case, which is really why you sent me the question. So those are my thoughts. Again, coming back to the letter, how I would phrase this to the doctor is that it's been a while. What you're trying to do is say, look, when you saw them, the threads weren't there, now they're there. That's not casting any judgment. If we take any other approach, we're likely to get into an ego war, and I promise you oral surgeons are not going to take to that very lightly. So we articulate the fact that things have changed since their last visit, and we would like him or her oral surgeon to take a look. Outline, take some screenshots. I would take a screenshot of this guy here. Just say, we noticed this on the CAT scan. Can you confirm that this is okay to now prosthetically load? If you ask all those questions and get the blessing from the oral surgeon and then you do it, you can sleep well at night knowing you did the right thing. Not treating this patient because you're concerned that things might be wrong might actually create more of a problem than it's worth. So that's where I'm at. I look forward to hearing your thoughts on this, but I think this is a great conversation for us to have about restorability of implants, whether implants are infected or not, bone loss, but most importantly, how to communicate with our colleagues in a way that's non-abrasive. All right, I hope this helps. Take care.